Good day everyone! My name is Rangas, a caregiving student from St. Augustine School of Nursing, Iloilo. And today, I'm going to demonstrate to you how to insert a nasogastric tube, feeding and removal of NGT tube. So the definition, a nasogastric tube is a pliable tube that is inserted through the client's nasal pharynx into the stomach, and it has a hollow lumen that allows the removal of gastric secretions and the introduction of solution in the stomach. There are four main purposes of the insertion of the nasogastric tube. First is to administer tube feeding and medication for patients who are unable to swallow by mouth or eat sufficient diet without aspirating food and fluid in the lungs. Second is to establish a means of suctioning stomach contents to prevent distension, nausea, and vomiting. Third is to remove stomach contents for laboratory analysis. And fourth is to lavage or wash your stomach in case of poisoning or overdosage. The materials that we need for the nasogastric tube insertion are as follows. We have stethoscope, the acceptance syringe, the nasogastric tube using the right size according to the doctor's order. We have tongue depressor, the water, lubricant, gel, the kidney basin, towel, sterile cloth, pin light, tissue, a glass of water with straw, and then safety pin. So for the assessment, first we have to assess the patient's need for nasogastric tube or nasoenteric tube, such as surgeries including the GI tract, impaired swallowing, or loss of consciousness. The nasogastric tube or nasoenteric tube will decrease the risk of aspiration for this kind of patient. Then, we need to check the physician's order. Checking the physician's order is very important, so we would know the type of tube to use, the size, the purpose of the insertion, whether it is for feeding or for suctioning, and also for legality purposes. Next, assess gag reflex. Assessing gag reflex is very important because the absence of gag reflex would mean an increased risk of aspiration. If gag reflex is absent, we should not continue with the insertion. Next, we also have to assess our patient's mental status or the patient's ability to cooperate. Now, by doing so, we will be able to plan for necessary reinforcements or also for easier giving up instructions. Next, determine the location of the materials, because some materials can be located in the unit or some might be ordered in the central services. This is to save time and effort. For the planning, we have to wash our hands to prevent the spread of infection. The GI tract is non-sterile, hence using clean technique is acceptable. Next, gather and prepare all the materials that we need, and as well as the equipment. The plastic tube must be soaked in a basin of warm water for 10 minutes. That is to soften that. And the rubber tube must be soaked in a basin of ice for 10 minutes. Doing this will help us avoid damaging the mucosa. Meanwhile, the small bore tube we have to use as toilet or a guide wire and position it properly. Failing to position this properly can contribute to traumatizing the mucosa. Next is to plan for assistance if necessary. Even though the patient may be alert, awake, or cooperative, the presence of somebody, being a medical personnel or a loved one of the patient, might be appreciated by the patient. For the implementation, first identify our patient, introduce yourself, and get the complete name and birth date of our patient, plus verify it by checking the wristband. Good morning, Sir Ryan. I am Rangas. I'll be your giver for today. May I know your complete name and birth date, sir?
My name is Ryan Perez. My birthday is December 14, 2010.
Thank you. May I check your wristband? Thank you. After verifying the complete name and birth date of our patient, the next step is to explain the procedure to our patient and the reason why. Upon explaining the procedure to our patient, we have to tell that it will be a little bit uncomfortable, but taking deep breath, relaxing himself, would greatly help. So Ryan, your doctor has ordered that we must insert a nasogastric tube to your stomach. This procedure will be a little bit uncomfortable, but if you take deep breath and just relax yourself, it will greatly help us. Inserting this tube is very important because you aren't able to swallow food that your body needs. The tube will help us to give you the medication and the nutrients that your body needs for faster recovery. Okay, sir, thank you. So after explaining to the patient procedure and also the reason why, we may now place the patient in high Fowler's position if it's not contraindicated. Putting the patient in high Fowler position is actually a way of using the gravity to help us during the insertion. The gravity can make it easier. Next, you have to put a clean towel on the patient's chest. That's to prevent the linen and the gown from getting soiled. Also, we have to prepare the tape for later application. We need to wipe the patient's nose using a cotton with alcohol to remove the excess oil. Since the nose is naturally oily, wiping it can increase the tape adhesion later on. Next is to assess the patency of the nair. We can use a pen light to check if there's any obstruction inside the patient's nose. So Ryan, I'm going to check your nose if there's any obstruction. Alright, good. Or another way is to let the patient blow air from the nose. So first we have to cover the first side of the nose and then let the patient blow. And then check the other side as well. So Ryan, I'm going to cover your nose. Please blow air. Alright, how about the other one? Okay, good. Well, this helps us to choose which side of the nose to insert the tube. Next, we need to have the kidney basin on the side of our patient and as well as the glass of water with straw. So Ryan, you are going to sip and swallow water from this glass with a straw later on to help us with the insertion. Okay, so we can have that ready on the side of our patient. Before we putting on with our gloves, as we open the container, we could actually use a sterile side to pour the water lubricant jelly. Using the sterile side would allow us to control the infection. Okay, so let's proceed putting on our gloves. After putting on our gloves, the next thing to do is to determine how far the tube is going or to measure the length of our nasogastric tube. And that is by measuring the tip of the nose to the tip of the earlobe and also connecting it to the sideward process. That will help us approximate the distance or the desired distance of our tube. The nose. Now mark the side with a tape as our indication of how far we will be inserting this to our patient's stomach. Doing this will allow us to approximate the distance that we need to insert the tube to reach the desired area. For nasogastric tube, we just have to add 8 to 10 centimeters of our nasogastric tube measurements. But of course, this will vary. After that, we may now lubricate the tip of the tube using our water-soluble lubricant. Water-soluble lubricant will just get dissolved if the tube is accidentally inserted into the lungs, hence it will not cause complications. Now that your tube is well lubricated, we may now gently insert the tip of the tube. We should have the patient's head hyperextend because that will flatten the curve of the nasal passage where it meets with the pharynx. We have to use gentle pressure and we should not force against resistance because forcing against resistance will damage the mucosa. So Ryan, I'm going to insert now the tube to your nose. Please hyperextend your neck just like this. Okay. After reaching the nasal pharynx, we have to flex the patient's head to the chest. That will close to trachea and also to make sure that the tube is in the right direction. So Ryan, please flex your head close to your chest like this. Let's now rotate the tube 180 degrees. Doing that, we will redirect the tube into the back of the throat and avoid entering the mouth. After doing that, direct the patient to sip water and advance the tube in 10 centimeters in every swallow. Doing that will ease insertion because the normal peristalsis. Sir, please sip and swallow water. Okay. There will be temporary gargling that would subside after you advance the tube. Once the tube is in, we need to take the tube temporarily. Now the tube is temporarily taped, we can now verify placement. But before that, we need to make sure that the end of the lumen is kinked and closed. That is to avoid the air from going in the patient's stomach and causing distension. Check the tube in the mouth using a tongue depressor. So Ryan, please open your mouth. Okay, let's see if the tube is in. Okay, alright. Good. So after doing that, we may now proceed with the other ways of verifying our placement. There are 4 ways that we can verify our tube placement. The first one is using the chest x-ray, which is not often done because radiation is harmful to our body. Second is to auscultate for barbaremy sound. Now, to auscultate for barbaremy sound, we would need our stethoscope ready. Okay, and also we have to use our aseptic syringe. Now, before we open the end of the lumen, we need to make sure that there is kink. That way, we are preventing the air from going in and causing this tension. So, insert now the aseptic syringe. And let go of the kink. Alright? Now, put the diaphragm over the epigastric area to listen for the berberimi sound as we introduce 10 to 15 ml of air in the patient's stomach. Okay, and the berberimi sound should be clearly heard if the tube is properly in the stomach. Now, another way to verify our placement is to aspirate the page content. To aspirate the page content, you have to remember to kink the tube. We don't need to remove the aseptic syringe since it is already here. So, kink the tube, remove the cover. Now, press the cover to create a suction sound effect later on. And then, we put the cover back. And let go of the kink. And release the cover. As you release the cover, you should be able to see some of the gastric content being sucked or pulled inside the aseptic syringe. Now that we have the aspirated content inside the aseptic syringe, we can now check the pH level. Now, we will know if it's in the stomach because the pH level of the stomach should be 1 to 5, and beyond that, it would mean that it is not the right direction or it is not the right location. Remove the aseptic syringe and make sure to kink and close it back. And test the pH level for the aspirated content. After verifying the position of our tube, we have to tape the tube securely. That's by removing the temporary tape that we used earlier and place the other tape plus the tape with this slate. And after that, we could use another tape on the top of the permanent tape that we used. Furthermore, we have to keep the end or the lumen plugged at all times. Secure the tubings, coil the free end, then pin it to the clothing. Pinning it to the clothing will make sure that the tube will not be dislodged upon movement. Next is to put the patient in a comfortable position that will make the patient feel better and elevate anxiety. So Ryan, you did very well during our insertion. Let's put you in a more comfortable position. After putting the patient in a comfortable position, we need to make sure to provide frequent oral nasal care. Because the patient's mouth and nose is expected to be a bit irritated since the patient is not breathing through the nose, or so that the patient is not eating using the mouth. So oral nasal care is very important. Next, we have to dispose our gloves and wash our hands for infection control. After that, we have to do an aftercare and return all the equipments that we have used. For evaluation, the very first thing is we have to assess the patient's tolerance during the procedure. There any discomfort, coughing, or gagging. Also for evaluation, we have to note the color, consistency, and the pH of the aspirate. Next, we have to ask the patient if he is comfortable. Sir Ryan, are you feeling comfortable?
Yes.
Thank you. Great. For the documentation, we have to initiate intake and output record. Also, we have to document the type and size of the tube that was inserted. Furthermore, we have to document amount and characteristics of the drainage. Next, we need to document our patient's response after procedure. Lastly, we have to add to nursing care plan the information for care needed. And that would be all for the nasogastric tube insertion. Let's now proceed to nasogastric tube feeding. The materials that we need are as follows. We need our feeding formula. Warm is indicated. We have stethoscope and drinking water and towel. For the assessment, the first thing that we need to do in assessment is to check the physician's order. We need to know the specific formula that we have to prepare and the water plus the time that we have to give the feeding. Next is to read the chart for previous observation on feeding. We need to do this to check our patient's tolerance of the procedure. Next is to wash our hands. Washing our hands is very important for infection control. After that, we have to determine whether the patient is to be using reservoir, asepto, or pre-filled method. For the planning, the first thing is to wash our hands for infection control. Next, we need to decide whether we have to use reservoir, asepto, or pre-filled method. Next is to gather the equipment that we need to save time and effort. For the implementation, the very first thing under implementation is to identify our patient to make sure that we are doing the procedure to the right client. Introduce your name, obtain the patient's complete name and birth date, as well as checking the wristband. Sir Ryan, my name is Luchirangas and I will be your caregiver for today. May I know your complete name and birthday, sir? Okay, now can I check your wristband? Alright, thank you so much. Next is to explain the patient what we will be doing and also inform the patient to let you know as soon as possible if he feels like vomiting. Then we can stop the feeding. Sir Ryan, your doctor has instructed to give you this formula for your feeding. And if you feel like vomiting, please let me know as soon as possible. That way, we can stop the feeding immediately, okay? Good. Next is to place the patient in semi-Fowler's position. Placing the patient in semi-Fowler's position will allow us to let gravity to aid us during the feeding. Sir, I will put you in semi-Fowler position. And also, the next thing to do is to drape our patient's chest with a towel to prevent linen and the gown from getting soiled. Next is to test the placement of the tube and for the residual formula, since it may have been dislodged in between feedings. To check the placement first, we can inspect the tube. After inspecting the tube, we can now auscultate for berberine sound. To auscultate for berberine sound, we have to make sure to kink the tube, open the lumen as we insert the septosyringe, put this stethoscope, and then pump or introduce 5 to 10 ml of air. Place the diaphragm over the epigastric area. After checking the berberine sound, we can now aspirate for residual volume. To aspirate for residual volume, we have to remember kink the tube. And since the septosyringe is already here, no need to remove it. Just remove the cover, press to create a suction effect, and then let go of the kink and measure the residual volume. Kink, open the cover, press the cover to create a suction or a vacuum effect. Put it back. Release the kink, and then check the aspirate and measure the residual. Measuring the residual volume will help us to check how much feeding to give if the physician order 110 ml of feeding. And if there's a 10 ml of residual volume here, we can just deduct the amount of aspirate, which is 10 ml from 110 ml of order. So it means that we may give 100 ml of feeding to our patient. After that, we have to put the residual volume back by pumping slowly or a septosyringe. Put it back by pushing it gently or slowly. After putting back the residual volume, we have to flush 10 ml of water. That is to clear the blockage along the tube. The total flushing, the total water we have to flush is 30 ml. We have to do 3 times flushing before the feeding, in between the feedings, and after the feedings. Next, if you're using the septosyringe method, we should just hold the syringe manually, fill and refill again. Do not allow the water or formula to fall below the bottom of the syringe because that will carry air and cause distension. To proceed the flushing, the same rule is applied. Kink the tube properly to avoid air from entering. Open the cover and then put 10 ml of water in the septosyringe. And slowly let go of the kink and let the gravity carry the water inside the tube. And back. Let the water fall at the end of the septosyringe since it will carry air and cause distension. After flushing, we can now proceed with our feeding. And remember to tell the patient that if he feels like vomiting, to tell you immediately so we can stop the process. Ryan, I'm going to proceed now with the feeding. Please, if you feel like vomiting, tell me right away and we shall stop the feeding, okay? To proceed the feeding, we have to remember to kink the tube, open the lumen, and insert the septosyringe, and then open the cover for the formula. Since the septosyringe is already here, all we have to do is to kink the tube properly to avoid the air from going in there and causing distension. Open the cover and put the warm formula. Let go of the kink and let the gravity take the formula in the tube and kink it back to avoid air from going in there. And then, between feedings, we also have to flush 10 ml of water to get rid of the blockage. Let go of the kink. Kink it back. And go on with your feeding again. Let go of the kink. Kink it back. Now let's proceed to the last flushing. The last 10 ml must be flushed in the tube. Get rid of possible blockage that might have stayed during your feeding. For the last water, let go of the kink. And kink it back. Uncover. After your feeding, clamp the tube or plug it and pin the tube to patient's throat. Reposition our patient to low Fowler's position, and if the patient is comatose, we have to put the patient on one side to prevent aspiration. So Ryan, let's put you in a lower Fowler's position. Next is to wash your hands. That's for infection control. Do aftercare. Return all the materials used. For evaluation, we need to return to the patient approximately 30 minutes. That's to make sure that the feeding has been retained. For the documentation, we need to record on medication sheet or progress notes the date, time, type, amount of formula, amount of water, and the patient's response, and including the intake and output monitoring. That will be all for the nasogastric tube feeding. Let's proceed to the nasogastric tube removal procedure. The materials that we need for nasogastric tube removal are clean gloves, paper towel, and oral hygiene tray. For For the implementation, first identify the patient. This will let us make sure that we are removing the nasogastric tube on the correct patient. Hello, Sir Ryan. My name is Lucy Rangas and I'll be your caregiver for today. May I know your complete name, sir, and your birthday?
Ryan Perez, December 14, 2000.
May I check your response, sir? Alright, thank you. Next is to explain the procedure to the patient. Let the patient know that it will be a little bit uncomfortable, but it will be over quickly. Sir Ryan, today our doctor has ordered the removal of your nasogastric tube. Since you have recovered and may now allow to swallow food using your mouth, it will be a little bit uncomfortable, but it will be over quickly. So, taking breath and relax yourself will greatly help. Okay?
Okay.
Good. Next is to drape the patient's chest using a clean towel. That is to prevent the linen and the gown from getting soiled. If suction is operating, we need to turn it off to avoid discomfort, and we have to disconnect tube. Put on gloves for infection control. After putting on gloves, we have to pinch the tube, close or plug it. That's to prevent acids from leaking. Our stomach is secreting hydrochloric acid, which is really uncomfortable. So to prevent that, we need to pinch the tube closed. The next step is to remove the tape. Coil the free end using our dominant hand, and we have to use a tissue to redraw the tube in a smooth yet continuous motion to avoid gag reflex. Place the soiled tube in a paper towel and cover it, and you may now remove your gloves. Next is to provide comfort to our patient and give mouth care to remove secretions in oral cavity. Measure the secretions in collection container. That's to record as output. Then we have to dispose the equipment and glove properly. That's to prevent cross-contamination. Wash our hands properly and to active care. We have to evaluate using two things. First, if the patient is comfortable. Second, there is no abdominal distension. For the documentation, we have to document the time tube was removed, the amount and description of materials in the collection container, and as well as the patient response. And that's it for the nasogastric tube removal. Thank you very much for watching this video, and I'll see you next time.